So I've got the longest title today, and the last line in there, lies, damn lies, and statistics. If you Google that, you'll see a bunch of internet memes with Mark Twain's picture on there. Of course, that's not correct. It's not what he said. In fact, one of the pictures of Mark Twain is actually Albert Einstein, so that makes it even more interesting. And you see these things come up in your social media feed a lot. So I thought I'd focus this presentation on when it comes to Pharmacare. Let's figure out what are the facts, what are the evidence, and as an evidence-based industry, it makes sense for us to continue to push forward that this decision and this discussion is evidence-based and to call out the BS when we hear it. So my compliance company is the only one, I think, who asked me to put in a disclaimer slide. So as you're reading that, I'll have a full disclosure here. I'm for Pharmacare, and I'm going to try to make the case that Pharmacare should go forward in Canada, as long as it has three caveats. First is that we all align on what the facts and the evidence actually are. Second, that Pharmacare actually improves access and equity to medicines and innovations. And third, that it actually gets measured properly. And that third one concerns me, and I'll give you an example of sometimes how our healthcare system measures things to make them come out the way that they always thought they would in the first place. So we just saw this from Carol, the discussion paper. I pulled out a quote from this discussion paper on this slide. And I'm going to ask you, there's a survey question coming up next. Equity and coverage has been a hallmark of the Canadian Medicare for the past 50 years. It also talks about access. So I've highlighted those two words, and I just want to get your opinion on it. So here's an audience question. Is Canada's healthcare system is one of the following 5 things? And let's see what the group says. Now, no matter what you say, I'm going to put this opinion forward as actual evidence to support whatever conclusion I've already come to. All right, here we go. Broken, interesting. You've got to pick the new music because there's a song called Broken, I believe, which I'll sing for you later if this presentation doesn't go well. So Broken, I was wondering what everybody would say. That's the opinion of everyone in the room. Let's go to some other third parties. The World Health Organization ranked out of 191 healthcare systems, we are number 30. What people love to point out is when they talk about how great our healthcare system is, it's always we're better than the U.S. It reminds me of when my son came out of the driveway a couple of weekends ago and he just said, "Dad, I just crushed my 9-year-old sister in a game of one-on-one." I'm like, it's great when you pick your opponent, but why don't you pick somebody your own size and see how you did against them? But here's another one, the Commonwealth Fund. Another third-party organization that ranks healthcare systems. In this case, they took 11 similar developed countries. You'll see the U.S. way out there on the right. So the U.S. consistently falls dead last in this. We came from second last to third last. The last time this report came out in 2017, it was hailed as a great success in some cases. This graph tells you about the money we spend and the performance of our healthcare system. So we spend less than the U.S., and on average, as a percentage of our GDP, roughly the same as the other 9 companies or countries that are in that were in this survey. So what did we fail on? Well, access and equity. Those two things that were put forward in the discussion paper on Pharmacare as absolute truths about our healthcare system. We came, probably no surprise, we came second last in access, but what was a big surprise is we came third last on equity, and most importantly of all, we came third last in healthcare outcomes. In fact, infant mortality in Canada is one of the worst in the world. So why is that? Well, let's go to some other influential figures in our healthcare system and see what they say. And I think Pamela brought out Andre Picard's name earlier. In his book, I think he describes our healthcare system better than anybody. It's islands of excellence in a sea of mediocrity. If you did want to get a transplant and you could find yourself on a table with a lung or liver available, no place better in the world than Toronto General Hospital. Problem is, you got to get on that table first, and that sometimes takes quite a bit of time. So in his article about our healthcare system in response to the Commonwealth Fund, he says, look, our healthcare system is not universal. Access and equity are well below standards. And he argues that we should have Pharmacare to cover or close some of the gaps. And each one of those other reports also say that Pharmacare should be a part of the Canadian healthcare system. So he's, I think, in my opinion, one of the most influential people in our healthcare system right now. Let's go to the second most influential person, I think. So I'm doing another presentation right now for the oldest people in our healthcare system, and I must have slipped up on a couple of the slides. So second most influential person in our healthcare system these days is Dr. Danielle Martin. If you haven't seen her speak or read her book or gone to her webinars, you absolutely should do this. She's going to be playing a much bigger role than she already is right now. So she's got a book, Better Now, 6 big ideas for healthcare. One of them is Pharmacare. We should have it in Canada. Another one is innovation. Embrace technology and innovation, which is something that we all agree with in this room as well. So it's nice to hear her say that. And she says one other thing. We do not need to spend more money, just like the Commonwealth Fund says. We don't need to spend more money. We just need to get more for the money we have. And in a follow-up report that she had to the federal government, Fit for Purpose, she recommends something that I think is long overdue but didn't quite go far enough. And this is the closing down of many of these pan-Canadian alliances and associations we have. So she goes through 9 of them and says, let's get rid of 3 and then fold the rest into 3. I would suggest she didn't go far enough, and we could probably take Health Canada, CADIF, PCODER, PMPRB, PCPA, throw in P. Diddy if you like, put them all into one place and have a discussion that looks like this. Your drug is safe, or your medical technology is safe. It's effective. We want Canadians to have this. Here's what we're going to pay for it. It's now reimbursed. Bob's your uncle, and you move on. Wouldn't that be better for everybody? I think it would save a lot of money and time, and certainly improve access. So what are some of the other voices? Well, here's the 4 horsemen of the pharmapocalypse, as I like to call them. You probably know some of the names in Lexington and Morgan, and they argue a few things. There's also a website you should go on called $1 Million Meds. They have a nice big 5-year grant from CIHR, and they say things like, experts agree there's no real justification for the high prices. No reference, no study to support it. Next time I go to Health Canada, I'm just going to say, experts agree that this drug is safe and effective and you should approve it. Or, because it's funny the things that substitute for evidence these days. Or you could take Brian Bloom's approach and just say it loudly with passion and people might believe it as well. So these other facts that are on here, I think everybody's well acquainted with, and I'm not going to go through them again. Here are some more quick facts in the Pharmacare discussion. And if these facts are true, if people have to choose between feeding their kids or heating their homes and filling their prescriptions, if people are dying prematurely, then as an industry, we do have to do something about this. And I know every company does some things, but clearly if these facts are true, we're not doing nearly enough. Now here's an article that came out, and there was another paper published by the same organization yesterday. And it talks about the myths in Pharmacare. And I think we're going about this wrong, and I think Brian's going to talk about it next. There are 95% of the people in this company do have some sort of private insurance, but the fact is that's still not enough when it comes to pharmaceuticals. So where do all the numbers come from when it comes to the pricing? We've heard these before. This comes from that same group, Steve Morgan out of UBC. His paper says $8 billion will be saved in private and societal costs, $1 billion in public drug costs. And unfortunately, this is like the subprime mortgage piece where everything's built on an assumption, on an assumption, and on an assumption. And the biggest assumption is here that we're going to negotiate lower drug costs and we'll save tons and tons of money. And this is now put forward as evidence or as research or as fact. And clearly, this is just opinion, despite the fact that there's a protocol and statistical analysis. It's not evidence and it's not fact. And so my hope is that we will actually measure Pharmacare. Whatever it looks like, whenever it gets here, we'll look back and we'll measure it correctly. But my fear is we'll see something like this. No matter how it looks, we're going to get a slide that tells us how great it is. And it's done everything that we said it would do, except for maybe a couple of little bumps that we have to iron out. So I'll give you an example from my world. Our product portfolio is mostly in the hospitals, so we don't deal with PCPA or CADIF. We sell to hospitals, and they have a group of people called buying groups across the country who we have to negotiate. And so here's the way it could work, here's the way it shouldn't work, and here's one way it absolutely can never work in the case of Pharmacare. We had one, and our product is a medical device. It's very complex. It's for critically ill newborns. It comes with a drug as well and a service of just-in-time solutions. And so one healthcare system came to us and said, we've evaluated your medical device. It's better than the 2 generic ones that have come to market now in 2016. So we want to do business with you because we can't trust that these other companies will have the just-in-time solutions. But he said, Robin, you can't embarrass me in front of the taxpayers. I need a good solution. I need a good price. Let's sit down and negotiate. And we did, and they got a very good price compared to what everyone else did. The rest of the buying groups we had to do an RFP for. So we went through RFP after RFP, and the very first one had a best price clause. So each and every one after that all basically got the same price. But what they do is when they announce or they document their savings, they all double and triple count each other's savings when they put that in their annual reports. And so the one that can never happen is what happened in Quebec, and Quebec went for the lowest price. They've gone to the lowest price, and now the other product, unfortunately, has caused significant adverse events. A baby has died. They have saved some money, but unfortunately it's going to cost them more money in the end. They've had every hospital write to them to cancel the RFP and allow them to go. There's been letters to the health minister, and still nothing's happening at this point. It used to be that 100 babies a year were transported on our product in Quebec on an annual basis. In the last 18 months, none have. And remember, this is a critically ill population of life-saving medications that we need. So I am concerned that Pharmacare won't be measured properly. I think after it gets implemented, maybe the facts might be skewed a little bit, but I am hopeful that Pharmacare does get here because there are gaps that we need to cover still. So thank you, and I'll turn it over to Brian next.